Hello and good morning, everyone. You're welcome to MEHID-Africa 2021. This is day 4 of the MEHID-Africa 2021 conference. We hope you've had quite an interesting time joining us from day 1. I'd like to welcome those who I can see in this room now. Adewale Samuel, Adebayo, Edo, Idi Odai, Festus, and Abilile, you're welcome. Ofuri Belokoto, thank you and welcome. Ms. Rosemary Akbitai, thank you. Vivian Omwemwe, thank you to everyone and the panelists and those behind the control room. I would like to say thank you once again. This is day 4 and this is the day we'll be going through the abstract series. Before I continue, my name is Yama Ehije. I'll be introducing the repertoires very soon. A quick rundown of what we had yesterday. We started with the readings for day 3, completion of readings of day 3, and then we started with the symposium, the third symposium for Wednesday. It was titled The Role of E-Health and Health Informatics in Healthcare and Health Management Information System. That was taken by Dr. Mohammed Idris. And then we went after to a special presentation by Dimagi Incorporated in the US, in South Africa. They deliver open source software technology suitable for low resource settings and undeserved communities. Dimagi as a company designs clinical interfaces, health information systems, and mobile technologies for patient-level disease management, clinical decision support, and health system monitoring. Then by 12:30, we went to the 4th symposium, which was titled Business Models for the Deployment of E-Health and Health Informatics in Health Systems. That was taken by Michael Prude, care of Professor Priscilla Pemu from the Morehouse School of Medicine, USA. At 3 p.m., it was the 5th symposium. It was titled Road Mapping for the Deployment of E-Health and Health Informatics by Dr. Lajide Adebola. He's the founder and ex-president Society for Telemedicine and E-Health in Nigeria and the chief technology officer and partner, Home Plus Medicare Services at Abuja. It was a very nice presentation towards the evening yesterday. Today we'll be going through the abstract. The abstract series will be starting plenary. That will start by 9:30 a.m. But before that time, we'll be having the readings for day 4. For those of us who registered for the conference, the readings for day 4 and your email already. Join us to go through the readings for day 4. We'll converge here again in about 23 minutes. That will be 9 a.m. and then we'll kickstart proper. But just quickly go through the readings for day 4 and try and glean 1 or 2 things you can from it. Once again, you're welcome to MEHID-Africa 2021. And I enjoyed us to stay alert. We'll be back with you very soon. Thank you once again.
Ladies and gentlemen, welcome to MEHID-Africa 2021. In a moment, we shall have the national anthem to start today's affairs. All right, thank you very much. We're sorry for starting a few minutes late. We are going straight into the first session of the abstracts. Today we are doing abstract presentations, and the authors are going to present their abstracts, and participants are expected to please follow through, make comments, ask questions, and the authors will respond accordingly. Thank you very much. On our team today, we have Dr. Vincent Adam, who is an associate professor of public health and community medicine, University of Benin, an honorary consultant physician, community physician, University of Benin Teaching Hospital, former acting head of department, University of Benin, former head of department, University of Benin Teaching Hospital. He has been kind enough to come with his wealth of experience to join our team this morning. You're welcome, Dr. Vincent Yakubu Adam.
Thank you very much.
Off your mic. Off your mic. Just wait. Okay. Eh, but let him be co-host first.
Good morning.
Good
Today
morning.
we are having the abstract presentation series 1. Unfortunately, the presenter for the first abstract is not online yet, so we'll go to the second one. The presentation title is Improving Health Literacy Through Mobile Phone in Rural Africa, a Literature Review. And it's a collaboration involving 3 countries, France, Burkina Faso, and Italy. The presenters are Guedraugo Ismaila, Bolly Michael Jonas, Some, then Benedicta Roland, and Diallo Goya. Please, if you're ready, you can make your presentation. Thank you.
Okay. Thank you so much, Vincent, and thank you all the conference team. Thank you for giving this opportunity to present our work. And I'm Ismaila Oudraogo, and I'm a PhD student and an assistant to research in health informatics at Bordeaux University in France. So I will be presenting our work on improving health literacy in rural area using mobile technologies. So as Vincent said, this work is also collaborated with the collaboration with some other professors, Professor Boris Some from Burkina Faso, University of Naziboni, and Professor Roland Benedicte from Iraq Research in Italy, and of course, Professor Gayo Diallo also from the University of Bordeaux. So this study is a part of a wide research project which intend to develop a mobile health framework that can help leaders to improve health literacy in rural areas. So health literacy, to give you a little bit of definition, it is the ability to obtain, read, understand, or use health informations to take decisions related to the healthcare. So as you know, despite of the tremendous opportunities that new technologies offers in many sub-Saharan African countries faces challenges to implement mobile health in rural areas specifically. So the aim of the current literature review is to identify the existing studies or initiatives that are related to the improving health literacy in rural area. So for that, we perform a PRISMA protocol in order to conduct our systematic review of published studies, and we use two databases, Scopus and Google Scholar, and we screened studies from 2010 and 2020, like 10 past years. So after identifying, screening, and doing eligibility phases, we included only five studies. So our findings suggest that that very few mobile technologies integrate today local languages in the design and the development of the mobile solutions. And if you, as you can also know, that illiteracy rates are very high in rural areas, specifically in sub-Saharan Africa. And because of the higher literacy rate, if mobile technology is not integrating local languages, it will be, health literacy also rate will be very low. That's why in our framework, we also think about developing solutions that integrate local languages, that take account local environment and realities in order to facilitate the accessibility of health information, specifically for rural areas. And this one will be a huge framework that can help leaders to be able to implement and to develop new technologies specifically for rural areas. So this is a small part of the project that we are working on. Thank you so much. If you have some questions, they are welcome.
What were the challenges you faced while carrying out this study?
Sorry?
I said, thank you very much for the presentation. What were the challenges you faced while carrying out the study?
Yeah, of course, the first thing, it is like initiatives, because there are some of the initiatives that were done, but they were not published and they were not accessible. So some of the studies and the technologies that were developed, but if they were not well documented to be able to get some of the feedbacks and clear challenges in order to think about. That is the first thing. The second thing also is we started thinking about what we can develop in terms of integrating new solutions. And as you know, there are many languages in Africa, and the solutions, like the how we can able to integrate those languages. The first challenges that we are now facing is like those languages are not written. They are not written languages, and to be able to use artificial intelligence, because it's the artificial intelligence and machine learning algorithm that we are working on. We are trying to automatize some of the voices, messages, and others. So because languages are many and they are not documented, it is very, very difficult to work on it. That's the first challenge that the main challenge first of all.
Okay, thank you very much. You said you only saw 5 studies that were related to health literacy and mobile technologies in Africa. Please, where were the studies carried out?
Yeah, these are where, yeah, like we are pursuing our studies because, as we told you, as I said, like some of the studies were not published, so we are also contacting like some of the institutions and to understand some of the projects. There are some projects that are intended to improve literacy, but they are not clearly mentioned. So in these studies, the study is not specifying on those things. But the most of the studies that were taken in specifically in East Africa, in Kenya, Tanzania. Yeah, there were also one study in Morocco. So of course, but West African also, like Nigeria and in Liberia also, there are studies, but it was not clearly mentioned like it is efforts that intended to measure. So we are working to gather all those informations.
Beautiful, thank you. But you know, you have so many indigenous languages in Africa. Is it possible to use things like, say, Pidgin? You have some languages that cut across board. That is, is it possible for you to maybe see if you can use things like a Pidgin language?
Mm-hmm. It is a suggestion because as you talk about Pidgin, like in Nigeria, there is a Pidgin, and most of the people speak Pidgin, as far as we know.
Yes.
For example, in Nigeria. So
yes,
the aim is really to be able to find maybe not a common language, but a language that people know, and how we can use artificial intelligence to facilitate the understanding of the information. Of course, Pidgin is a very good ask and solution that we can think about. And as I said, if the language is not written and to be able to code, it is like a bit difficult. But I think Pidgin, for example, as far as I know, it is a very big piece that we are working on, and of course.
Okay, thank you very much. Yeah. This is a nice one. So what would be your recommendations now with respect to improving health literacy through mobile phone in rural Africa?
Yeah, first of I think the health organizations also, is in one of their declaration, they mentioned health literacy as one of the important key points to attain sustainable development goals, because to improve SDG 3, like improving health for accessibility of health for everyone by 2030, we have also to improve health literacy to facilitate the accessibility of health information for all. So for that, like policymakers, like leaders and decision makers must like include, of course, health literacy in their agenda in order to work on it. And if the accessibility and this information are not on the policies, it will be difficult, of course, to work on it. And research also must work more on those topics, because when we check in other countries and in other continents, they are more advanced in health literacy area. So it is more researchers must like more focus also on the issue, and also policymakers also must of course support by finance also studies that are occurring in the area.
Thank you. Do you think the government can play any role?
Of course, they can play. That's what we are appealing for them to support the initiatives that have been occurring by financing and facilitating the implementation of such projects.
What about the communication commissions? Do you think they have any role to play with respect to improving health literacy through mobile phone?
Sorry, communication?
Communication commissions.
Of course, they are very strong partners in such projects because they are the one who know better about communication and accessing of information. It is first like the job of those who are in the communication sector. So we are just because we are in the self-information sector. We are just, if we put in place in technology, they are the one also must maybe validate understanding the feasibility of the solutions.
So how do you think you can maybe overcome problems like power supply, connectivity, and even the equipment itself, the phone? Because you're talking about rural area where poverty is relatively high. So how do you think you can overcome such challenges?
If I understand, you are talking about like poverty. Because of the poverty, it will be difficult to access the
power supply. You know, power is a major problem in Africa.
Yeah, we thought about it. You know, like let's say like mobile app, for example. Those are things that are difficult,
yes.
But solutions that we are thinking now, it is like there is a solution now we are working on. It is like we call 321. It is a solution that can just a simple call on a specific number.
Yes.
The person may be able to communicate directly with a system. Understand?
Yes.
A centralized system in his own language. So the information are stored there, and when he just call for free, because now this solution exists and it is feasible. Like there are many telecommunications companies that have such a systems, even but not in specific in the health sector. So such a solutions can help. The patient can, or the individual can call directly to this number and say, for example, I want information about COVID-19, and directly the system will will give information about that. And if he's not satisfied, you ask another question again. But for that to happen, it really need like a strong machine learning algorithm and a very strong working that is the main challenge that we are working now. If not to overcome, I do agree with you that power problems and poverty, those are another challenge. But to overcome those things, and there are new solutions that exist and that we can work on it that can be helpful, but it will really need a lot of work also.
Oh, beautiful. I say that you are based in France, and you are based in France, and one of your collaborators is based in Burkina Faso. So, if you want to carry out this thing, where exactly in Burkina Faso do you intend to carry out bring out these innovations?
Yeah, me myself also, I'm also working like in the lab in Burkina, because experimental work are not done here in France. So we are intended to do our experimental work in Guinea and in Burkina Faso, because we have partners there like West African Health Organization of ECOWAS. There is ECOWAS has an institution in Burkina called the West African Health Organization. So the idea is to work in partnership with them if there is a develop and a clear solution that we have been to develop, to be able to spread it to other countries, working in collaboration with ECOWAS institution there.
Okay. You mentioned Guinea, you mentioned Burkina Faso.
Yeah.
What was the major language, indigenous language that you can use for those two countries?
Yeah, first of all, now maybe I didn't mention it, but like Professor Gayo Diallo, for example, is now even working on a COVID-19 project, which intend to develop such a solution that I'm talking about in Burkina now, and for now we are developing in 3 languages, like in More, Bambara or Jula. I don't know if you know those languages. And in Fulbe.
Beautiful. So are you incorporating the local people to interpret some of the terminologies? Because how do you break down some of these terminologies?
Yeah. That is the work that we are now doing. So the thing is, there is test phase. Now we are not in the testing phases. We are in algorithm. We are developing the algorithm. But in the future, and the aim is to be able to test it with the people. So the languages, because sometimes the language of the patient, the doctors are not understood by the people. So it's the people who will test it, and will take specialists who will evaluate to know if really they do understand what are the kinds of words and terms that they do understand, how do they understand them, to be able to improve.
No, that's what I'm saying now. Take, for example, you have so many technical words, medical words and everything. It will be nice for you to have local people who help you interpret. That way, you will have like a universal language, yes.
Yeah, I understand. Yeah, those will, of course, those are even now recruited. We are in the team. There are local people who knows both the language and the local realities, and also scientific words. They will they will be the interpreters. Yeah. It's fine. Yeah.
Thank you very much. I don't know. Do we have anybody in charge listen to ask questions? Or comments? We have comments from participants. You can indicate by raising up your hand. If you have questions, comments. The topic we are discussing now is improving health literacy through mobile phone in rural Africa, a literature review. And the team of presenters from France, Burkina Faso, Italy. But for now, I'm discussing with Ismaila Drago. Can we have some comments? You can indicate by raising up your hand. If not, I don't know. Ismaila, do you have any other thing to say with respect to this your presentation?
No, I don't have.
Okay, thank you very much, Ismaila, and your team, and we're looking forward to seeing the end of this year project, because I know that it will help us a great deal if you are able to disseminate the information in local dialect. It will be of great help. Understand? Because we know that literacy is a big problem in Africa. Or Nigeria, for example, the lingua franca is English language, but there are some things that you need to disseminate to the people that you have to speak in their language for them to understand. So we wish you success in this your study. Thank you very much.
Thank you so much. Thank you so much for this conference, and I wish you all the best.
Thank you very much. We just heard from Ismaila, and he presented Improving Health Literacy Through Mobile Phone in Rural Africa, a literature review, a work that is done in collaboration with France, Burkina Faso, and Italy. Thank you very much.
Thank you.
All right. Hello, everyone. Sorry. We're waiting for the next presenters, and they are to present Understanding Health Information System for Health Planning and Decision Making, implication for achieving universal health coverage in Nigeria. We have a team of authors from Department of Economics, Nnamdi Azikiwe University, Awka, Nigeria. But for now, none of them is online. Please be with us. Thank you very much. Greetings, everyone. In order not to waste time, we'll go to another presentation. I'll bring it forward the presentation. And we have Iyama E, Idome F, Osawaru S, Osaweri T. They'll be presenting digital health marketing, the new revolution in healthcare delivery. Iyama, are you ready? Is any members of the team ready for the presentation, please?
Yes. Hello and good morning. I hope you can hear me.
Yes, we can hear you, please.
Good. My name is Iyama Ehije. I'm one of the co-founders of 247 Medic and 247 Lab Tests. I have a presentation this morning. Can you hear me now? Hello, can you hear me?
Yes, I can hear you, please.
Okay, I apologize. I think it was a network glitch.
It's okay. Please go ahead with your presentation. Thank you.
Okay. My presentation this Hello, can you hear me?
Yeah, welcome back, Iyama. We can hear you.
Okay, I apologize for the glitch. I think we should go straight into the presentation proper. I'm trying to move my screen. Okay. Like I was saying earlier, the ratio of doctor to patient in Nigeria has been said
Sorry,
to be...
if you don't mind, can you start all over again? Because we lost a great deal of time. So start all over so that we can follow. Thank you.
Thank you very much, sir. My apologies for that. My name is Iyama Ehije. I'm presenting my presentation is titled Digital Health Marketing, the New Revolution in Healthcare Delivery. I'm here representing 247 Medic and 247 Lab Tests. I was speaking earlier, I was talking about 247 Medic actually is an online app that connects you to the doctor, connects the patient or the client per se to the doctor. We are able to make online requests for investigations as well as deliver drugs to people that need it, whether in rural or urban areas. It is documented that the ratio of doctor to patient in Nigeria is 1 to 2,000, a little above 2,000. And Nigeria's healthcare status is rated as 187 out of 191 countries in the planet. Of 300,000 Nigerians who die of malaria annually just because they were not born in US, in Europe, or Dubai, or somewhere else, 250,000 have been documented to be children below the age of 5 because 20%, only 20% of our primary healthcare centers are actually functional. It's possible that one Nigerian woman dies every 13 minutes, 109 daily, as that's documented, and it has been said that mobile text messaging could save 147,000 lives annually. Someone visits a hospital, for say a tertiary hospital, for example, it takes about 4 to 5 hours to do documentation, taking the vital statistics before it finally sees the doctor for about maybe 10-15 minutes. That is labor loss and time gone. That time would have been saved if it's possible for the patient or the client to be able to access the doctor virtually. Consultation is done virtually, and if there's a need for laboratory investigations, it could be ordered online. That is what 247 Lab Test does. You make your request online. The client is ready and wait. The person is ready and waiting to attend to your needs, depending on the locality you are. Collects your sample on site. The investigation is done, and the results are sent to the platform. 247 Medic is an app that provides patients in cities and rural areas access to call or chat with the doctor, request on-site laboratory service, and get drugs delivered to their doorsteps at the comfort of their homes or offices. It's a telemedicine online advisory app connecting patients to doctors with a maximum waiting time of 10 minutes. It provides patients in cities and rural areas the opportunity to call or chat with a doctor. I've said that earlier. Basically, we are delivering affordable, subscription-based, cost and time-saving healthcare services through mobile platforms and by virtualizing healthcare services, which is what we need. On your screen is a photo shot of the app. The person could be a patient or a doctor. Doctors register on this platform. The patient downloads the app. That easy. Once you download the app, you register online, and then it takes about 2 to 3 minutes maximally. If Tony, for example, is a client, after he registers, he could call a doctor, he chats with the doctor, or gets a prescription from the doctor. That is the display of the app, the user interface, basically. So on the left, you can see you talk with the doctor, you have your chat history, you have your new lab test, which the doctor orders for you. Your lab test history is there. So wherever you are, your lab results could go with you at any time. The doctor and the patient only have access to this, and wherever he wants to access a doctor, he could have these things brought to him. It has been documented that telemedicine could reduce emergency room visits by 15%, admissions by 20%, and tariff costs by 8%. The American Hospital Association has told us at 76% of consumers prioritize access to treatment over face-to-face visits. We've seen in the last 18 months during the COVID pandemic that people actually want this at their convenience because of ban on proximity and gatherings. It is possible for people not to get to the hospitals or access treatment the way they would. There was a challenge in accessing healthcare. 247 Medic, 247 lab tests could bridge this gap, whereby patients could sit at the comfort of their homes, make requests, discuss with the doctor, and then when the request is made, samples are collected from their homes and the results sent to them. It has been said that Nigeria remains Africa's largest mobile market with about 162 million mobile subscribers. From here, we see there are 91 million internet users in Nigeria, despite the fact that we have those who have access to Androids or smartphones are 21 million. So we have potential for growth. And this could be something that we could look into in the future. WHO has told us that we have 5 billion Nigerians who die from chronic disease within the next 10 years. 22.1% of Nigerian youths in school below ages of 17 abuse drugs. From the last statistics on HIV/AIDS, we said 3.1 million Nigerians are living with HIV. Most of this number are unaware and are spreading it. So 247 lab tests, like I said earlier, is a mobile laboratory service app designed to provide on-site medical laboratory services, test kits, and deliver blood to emergency rooms anywhere in Nigeria. There's a process and there's a way we are going to carry it out. The first process, like I explained earlier, you download the app on the web, you request your laboratory test, you specify on-site location, a mobile test unit that is waiting response. And then the medium is through either a mobile app, responsive web application. We have a desktop application for those who are using their PCs, and there's an API for third-party integration when we want to attach to hospitals or HMOs. I talked about this earlier, but the clinical laboratory market size has been estimated to exceed $261.42 billion by 2020, and much more above that by the end of 2023. We are pitching for each investigation with a profit of 500 naira, and for a request of 500,000 requests will give us about 250 million in 3 years. Our target market is hospitals and HMOs, schools, churches, market unions, business, and of course, individuals. We have partners we are discussing with already. These are screenshots of what we have done in the past. It's good for us to tell that healthcare, basically, despite the business part of it, healthcare needs to be accessible, affordable, and it must be quality. That is what is important to us, and that's why we are 247 lab tests and 247 Medic are looking on. We've partnered with different people. We've got awards and sponsors from Tony Elumelu Foundation before now, Edo State government, the federal government, and GTEX in Dubai. Thank you very much.
Thank you very much, Iyama AJ, for that presentation. I'd just like to ask some questions. What do you think is the major prospect for digital health marketing in Nigeria?
The prospects for digital health are quite far spread. Prospects for digital health are very, very bright, looking into the future. People actually want to do things at their convenience. Currently, this conference, people are sitting at the comfort of their homes and offices, and we're all in one virtual room, and we're gleaning knowledge from what is being shared. Some people do not want, for example, when we do HIV tests at particular outreach we went to, some people didn't want to be present there to be able to know their status. They preferred to make calls or will come collect their samples in their homes. And this convenience is what is one of the major parts we are looking at. It's convenient for the clients, it's comfortable, and considering the fact that access to internet and mobile phone technology is still growing in Africa, especially in Nigeria, considering our population, there are great prospects, and this will make healthcare affordable even in rural areas. You can get to the hinterland in Nigeria now, and you can have telephone subscription and internet technology. So it's going to help to make the world much more a smaller place virtually, despite our distance, and people can have access to healthcare despite where they reside or where they are based.
Thank you very much. So what are the infrastructure you think should be put in place for this to be achieved?
Beautiful. Aside mobile phone technology, access to to mobile phones, the networks operators, and internet service providers. One of the major things is electricity. If there is power, these things will be able to ride on that strata comfortably. If there's access to electricity, to even in the hinterlands, then every other thing will work seamlessly. That's what I think.
Thank you very much. The way you presented it, it's as if once you start the process in 10 minutes, you already get to your client. Have you ever considered that transportation might be a problem?
For 247 lab tests, it's not actually a central location. We have partners at different locations. When the person makes a call or goes to the app or makes a request, we look at the person's location. We geomap. Each city we want to be in will be geomapped. When we did a test run, Benin City was geomapped, and we had different hospitals and different laboratories whereby the samples we picked, whosoever is closer to where the client is dispatched to go get the sample. It is analyzed at a specific laboratory or hospital. It is done there, then the result is moved to our database, whereby it is and they're sent to the patient. It's not from a central location, because you can't be considering this morning now there was a downpour. If I'm somewhere in the northern part of the city and somebody else is in the eastern part or southern part, access and to be able to get there will be difficult. So we first of all know where the client or the patient is making the request from, then we'll dispatch whoever is closest to the client to carry out the service.
Nice initiative. The healthcare workers, are they always on standby? The clinicians, will they always be on standby? This is a 247, and that means at any time you can have access to the client. Are they always on standby? Don't you think you're going to have a problem with that?
You're not far from the truth, but for the test run we did at a particular time, we did it for about 2-3 weeks. We had some doctors who were part of it. We had some lab scientists who were part of it. Actually, apart from emergency cases, maybe some things happen at night or hours beyond regular time, daytime, there were only few who made requests or wanted to chat to the doctor at those times. The doctors, the lab scientists, they are always on standby. And like I said, it's proximity based, depends on where the client is located. That's what determines who will be dispatched to meet the needs of give the services to the client.
So what are the possible challenges I think the clients might face in order to access this? What are the possible challenges they face?
If one of the first and major challenges apathy towards technology. Some people had told us when we did a survey, we gave us some questionnaires, they were telling us they might not have access to, they might not know how to use it. Some others said they didn't know how to use Android phones. There was another group that said what of instability in the network or service at the time, which is beyond us. And those are some of the major challenges. Apathy towards technology, one. Secondly, ease of access. Then we have some things that are beyond our control. We've actually been able to discuss with some service providers. It showed prospects, but when we fully get good enough funding, we'll be able to discuss with them maximally and be able to sort it out. That's it, sir.
Thank you.
Yes.
What is the cost implication to the clients?
Okay, for cost, the plan is to make healthcare affordability is the first thing, quality, and that is affordable and that is accessible. That's why we're able to move to the client base and then collect the sample. We are looking at pitching profit per investigation or per contact with the doctor, per consultation at 500 naira. That's what we are looking at it basically, because something that if we are able to get partners who can partner with us and provide some level of funding, that's what we look at to make it affordable and accessible. But despite being in the urban areas, we are also looking at penetrating rural areas. Our healthcare facilities, primary healthcare facilities, especially in Nigeria here, it's still a work in progress. Only about 20 to 30% of the primary healthcare centers are supposed to provide healthcare to people in the hinterland are quite functional, as we know, for those in the healthcare space. So we're trying to bridge that gap and make sure we these people have access to healthcare, because most of these healthcare centers, I'm putting someone, and most of these healthcare centers do not have the qualified workers at the time when they are needed because of their locations. So if we're able to access these places, I think it will go a long way to alleviating the problems that are faced, healthcare problems or challenges that are faced in both rural and suburban areas.
Thank you very much. You say 500 naira flat rate. Do you assume?
No, sir. So as profit, not as cost. 500 naira as profit per investigation.
If you don't mind, can you give an example of investigation? Then top it up with your 500 naira this thing.
Okay. Just give me a minute. If, for example, somebody wants to do an investigation, if I want to do a PCV investigation, I want to do a PCV check rather, and we looked at costs and prices of these different investigations in both private and public facilities, and we said, okay, if it's something that should not be, even if it's most of this investigation are out-of-pocket expenses for patients and clients, we want to try as much as possible to reduce it to a large extent. And then we decided to pitch it. If, for example, a PCV check was going to cost 300 naira, 400 naira at a facility, I should not be beyond maybe 20-30% of it for logistic purpose. An investigation like electrolyte urea creatinine is about 2,000, maybe cost, let's say 1,500, cost of materials and every other thing. The maximum amount of profit should be on that 1,500 naira. If it's for electrolyte creatinine check, should be 500 naira. So make it 2,000, which for presently is quite cheap. If you look at public facilities and even government facilities, for an EU creatinine to be 1,500. So we're looking at not making it expensive beyond the reach. Like I said, affordability is one thing we're looking at, and it should be quality as well, and everybody should be able to access it.
I like the initiative, but the thing is, I don't know how you're going to break even, because you're going to collect samples from people's house, you're using transport, and your profit margin is just 500 naira. How do you cope? How do you think you break even?
Yeah. One of the slides I shared that's currently on the screen now, because of awareness of healthcare, if the awareness is actually made about 247 medic and 247 lab tests, we're looking at having partnership with hospitals, having partnership with organizations. We're looking at HMOs as well. So if we target, for example, 500,000 investigations, not people, like on the slide. Okay, for a company, if we're working with a company now that has about 100 staff, and per time per circumstance, they make orders for maybe, let's say 20-30 investigations per month, or maybe a little above. So we're looking at investigations that will get to 500,000, not individuals. So we're looking at 3 years. If it's 500 naira as profit on each one, 250 million naira within 3 years. And it's not just on demand. For example, there are people who want to do some people come to the hospitals where I work now and say they want to know their blood group, their HB genotype, for example. Those are things that might take their time. They leave the comfort of their offices, they are busy, quiet, and they come to the hospital. We go to their present locations and we get the samples, analyze it for them, and send them the results. So when people see such efficiency and such flexibility, which saves time, I think for word of mouth and for people who will be willing to partner with us to go a long way. This is just a start.
Thank you very much. So from what I'm hearing now, it's as if your major target is not those with health insurance.
No, I will not agree with that. We are looking at, like the district government recently started their health insurance policy, and we're looking at partnering with them as well, because we 247 Lab Test got a grant at the time, 2018, at the Allow Without Summit for 500,000 then, and we're looking at partnering with the district government. Health insurance, because of out-of-pocket expenses of patients and clients, it could be expensive. If the government could subsidize it, or this individual, for example, corporate companies could subsidize for their staff, and they pay a premium, particular amount of premium every month for their staff. It will go a long way to helping us recoup and making it much more efficient. Is one of the parts we are looking at actually.
Thank you very much, Iyama. You've just listened to Iyama presenting digital health marketing, the new revolution in healthcare delivery. I don't know whether our participants have questions, comments for the presenter. If there's no question or comment, I think we'll go to the next presentation because the presenter is on standby. Okay. Thank you once again, Iyama. It's almost 11 o'clock, so we'll go on break. Please, all the presenters, any presenter that is on the platform, they're ready. We already have somebody on standby. We're not using the initially proposed sequence of presentation so that we don't waste time. So we'll go on break. We'll go on break for 30 minutes. Thank you.
Good afternoon. Well, it's morning in Nigeria, afternoon elsewhere perhaps, and it's much earlier in the morning in the US and so depending on where you are. Greetings to you. We are moving into series 2 of our program for today, looking at the abstracts. We shall soon be checking the fourth presenter. So at this time, we have a paper to be presented titled "A Case of Taurus Latinos Accurately Assessed via Phone and WhatsApp Images." This paper is authored by Dr. E.D. Odai and Dr. S. Adetunji. To present it is Dr. S. Adetunji. Dr. Adetunji, you have the mic.
Okay, thank you very much. Thank you so much, sir. I hope I'm audible. Please, can you hear me? Hello, please, can you hear me? I want to be sure that I can be heard. Hello, please, can you hear me?
Hello, we can hear you.
Oh, okay.
We can hear you.
All right, thank you very much for the opportunity. As announced, we're going to be taking a case report as a case of a Taurus palatinus accurately assessed via phone and WhatsApp messages. And it's actually a case of a 45-year-old woman who resided at Edo North Central and complained of a painless swelling in the roof of her mouth, which she noticed a few months earlier. The lesion was actually an incidental finding while she was examining her teeth in the mirror. According to her, she described the swelling as such that is located in the midline and symptom less. She has not noticed any increase in the size of the swelling when she was first noticed. So we asked for a picture of the lesion to be taken, and it was shared through WhatsApp Messenger. The picture showed that the lesion was truly located. The picture showed that the lesion was truly located at the midline of the palate, as described by the patient, extending posteriorly and with the same color with the surrounding tissue. Now, further questions on the lesion characteristics suggest that it was firm to hard in consistency and not tender to touch. So an assessment of a benign lesion was made. I have a picture of that the patient sent to us at that particular time. I tried to reorientate it so that we could appreciate the lesion in the center of the palate there. That's swelling in the center of the palate. So after assessing the lesion from the picture and all that, patient fear was allayed and given appointment for a much later date when the clinic became admissible for more patient inflow. That was about 3 months later. And then we continued to share periodic pictures of the lesion to monitor the growth and comparing with the previous one that the first one that the patient sent. Now, at the end of the long waiting for the appointment, the patient finally presented at the clinic and the lesion was reassessed. And it was truly found to be essentially the same as described by the patient, and a diagnosis of palatine torus was made. Now, a brief discussion on this. Now, telemedicine has been described as any care delivery model whereby patient care is provided at a distance using information technologies such as cell phone, computers, or other electronic devices. It has also been described as an effective way to alleviate hospital congestion and to improve medical resources utilization. The novel coronavirus pandemic has further underscored the need for telemedicine exploration and utilization in today's healthcare delivery. Now, we have studies that have shown that telemedicine improves access to high-quality healthcare services through advanced communication, improve the equity and efficiency of health service delivery, and increase the patient access to specialist expertise care that was difficult to access before. Now, our patient benefited from these advantages despite being in an area where access to tertiary health care is difficult. More so, the fact that the consultation request came at a time when COVID-19 pandemic put a limit on the number of patients that can be reasonably seen per time was another critical factor. Now, this method of consultation therefore saved time of assessing the healthcare need, saved cost of transportation for the patient, and reduce the rate of exposure of both the patient and doctor to the virus. Also, the fact that the patient was able to get the needed medical attention on time helped to reduce anxiety and worry by the patient. This method also allowed ease of follow-up till the patient long appointment was due. Now, these are in agreement with the work of Kilo et al., who showed that telemedicine has become a means of a forward triage, which allow patients to be triaged before they ever visit healthcare center amidst this COVID-19 pandemic, thus allowing healthcare providers to give priority to the emergency cases while giving long appointment to others, as it was in our case. Now, this method also maintains patient-oriented care and protect patients and healthcare providers from patients who may have COVID-19. We therefore recommend the use of telemedicine as a pre-appointment tool for patient triage and early management. Thank you for your attention.
All right. Thank you very much, Dr. Adetunji. You have presented a very important paper, and we're going to look at some things here. And I hope that the participants are getting their questions and comments ready. Please, if you have questions, if you have comments, put them up in the Q&A section, upload, and let us have access to them. Okay, to start with, Dr. Adetunji, can you please tell us briefly what torus palatinus means? It's a benign lesion, yes. Tell us a little more about it.
Thank you.
Why does it require intervention?
Okay, sir. Torus palatini is actually a benign swelling. It's a bony swelling in the midline of the palate. It's like I said, it's a benign swelling. It could be there without disturbing the patient for a very long time, and it doesn't often require treatment. You know, in the case of our patient, because of the size of the lesion, it doesn't really require any intervention. However, if it's big enough that is disturbing the patient's speech or tongue or speech or whatever, then that might necessitate intervention. But in the case of our patient, it wasn't really required. So basically, it's just a bony swelling in the midline of the palate. It's a benign lesion, does not disturb the patient, and
I noticed you were very careful in the choice of your recommendation in what you presented. But we don't have that written. we noticed that what you presented
Yes, sir.
is a bit different from what you wrote down to us. Some information is missing. We would request you to please redo this abstract with the best of information you have. Otherwise, your reader will not be well guided. But I still maintain that you've done a very interesting work. In doing that write-up, please ensure that you put into consideration the comments that we're making so that we can have the best. It is commonplace to take photographs and send to your doctor. Why is yours special? Why does it require attention?
Okay, sir. Thank you very much, sir.
Yeah.
Now, the peculiarity of this and why it became very interesting was first the time the patient was going to present to the clinic, which so it's more like something that started on, okay, let's see the picture of what you have and all that, and then at the end of the day we found out really it's one of the cases that ordinarily would have deferred, till other time, because it was coming at a time in which we're trying to restrict the number of patients that we see because of COVID-19 pandemic. So we wanted to attend to only emergency cases. And now this patient, I found this thing in my mouth is disturbed. I mean, I'm disturbed, I'm worried, and okay, let's have a snapshot of what you have. And then we found out that just looking at it and diagnosing it afar off, we could actually reassure this patient that no, there's nothing to worry about. You could wait till this also time. And eventually, when the patient came, we found out that it was a very good decision taken at that particular time. So we saw that why not explore this method more? Because indeed, another peculiarity is that this patient was in a place where ordinarily tertiary care would be difficult to. Would have been difficult for her to access a tertiary care, and just giving us the snapshot of that lesion from there, analyzing it. That's actually what made it a big deal. The fact that a good decision was taken at that critical time, because of that COVID-19 pandemic. Otherwise, maybe we would have just asked the patient to come down. But taking that decision and finding out at the end of it that was the best decision, taken at that particular time. The patient got the diagnosis, were able to allay her fear. She didn't have to rush down to this place, and we felt that was worth sharing, and that it may help us or it may be a way of it may help us to advocate more on the need to use this telemedicine, especially
Dr. Adeshiji, please. Can you please display the last page of the last slide you had before the references?
Before the references, okay, sir. It was shared from your hand, but I don't know if I'm allowed to share from here, or maybe from situation room. I had mine here, but let me see if I'm allowed to share.
Okay, I think we have it on screen now.
Okay.
The answer to your question is captured here. As a pre-appointment tool for patient triage and early management.
Okay,
Can we see the slide preceding this?
Okay.
Yes, so patient-oriented care and protects patients and healthcare providers from patients who may have COVID-19 and other infections that may be transmitted through the respiratory route or airborne infections from direct transmission from persons who are infected. So I think that answers the point. But critically, the idea of having a pre-appointment tool is very important. It makes assessment faster. Even when the patient presents himself, the doctor is able to make much faster assessment and take very quick decision. When management has already commenced before coming to the clinic, it also makes the entire clinical management time shorter. And these are important economic issues. So we'll be happy to have you highlight these in the next, in your eventual submission. You have done a very important work. Now I'm going to ask you another question. WhatsApp as an application usually reduces the quality of images. Is there a lesson you'd like to share with us on that? It's important you state this because it will help users, those who want to follow from here, to know how to handle images on WhatsApp. Did you tell the patient or the caregiver to take any precaution or follow any instruction with respect to handling the image?
Okay. In the case of our patient, really, I guess because the patient used a phone that had a very good camera, I mean, megapixel, maybe very high megapixel. Because when the picture came, the quality of the picture was not so distorted as it were. So I didn't quite we didn't quite pay attention to that. The quality, as it were, the quality came in good enough for diagnosis.
All right, thank you. But I think there are a few more things that users should learn there. The PNG format tends to preserve the quality of picture, and then if pictures are transferred from WhatsApp to another device using the document function rather than the picture function, that will also help to preserve. Generally, document function helps to preserve the quality when you are coming into or out of WhatsApp. So that's to help those who want to use it. But very good pictures are very important for diagnosis. For example, if you saw a hemorrhagic torus platinus, you will probably not be looking at it as a mere torus platinus. If you notice hemorrhage there, and without a good enough picture, you may miss that point. An approach to diagnosis will differ. Suppose the patient already had melena and the bleeding there is sufficient to cause that. Of course, your approach to diagnosis may differ a bit. That's just for us to learn. But I still say that you've done a very good job. We need to learn how to use simple technology that is already available to achieve healthcare solutions. Even if those forms of technology were not originally developed for the purpose of patient care. That's the lesson we are sharing here. I thank you very much. We still don't have questions or comments from our participants, but I'll ask you one more question, and I think it's an issue you need to address just in one sentence in your eventual write-up. But let's talk about it first. What do you think this approach portends for electronic medical records? What guarantees are there? What limitations are there?
Thank you, sir.
Yes.
Well, I believe that there are potential, there are a number of potential things that we can explore.
Sorry, maybe your mic needs to be closer to your mouth. Hello, Dr. Adetunji.
Hello, sir.
Now you are very loud and clear. Very loud and clear now. And let's keep it so.
I said I believe there are a number of benefits that we tend to derive from usage of this method. And just like you said earlier, it's not to say that there are no certain there are certain limitations also. One of which you just pointed out, because we're looking at something that will be so simple, that will be very simple for patient to be able to use. By the time it require conversion from picture to document, because we want to maintain the quality of picture taking, it makes it. I'm not sure. Many patients will be able to go that far, in terms of converting. So if it's becoming more complex, it becomes an issue. So it should still remain something, something simple, straightforward that patient can make use of, so that the information can be transmitted. However, maybe we'll have to battle with the issue of the quality of the picture, just like you pointed it out. But
Okay, so let me draw attention to what I think you might want to pay attention to. One of the things we try to achieve in e-health and health informatics is that from the point of patient assessment, clinical assessment, to the end point of data collection and storage and processing, it must be seamlessly electronic. That means that in the database of your clinic, that interaction that you had with your patient electronically should be captured real time. That's best practice that we require. So as you got that picture, there should be a system that captures it in your database. The inability to do that is a limitation. That does not mean that your recommended technology is not useful. No, it's very good, very useful, but please keep that in mind. And the reason we need to emphasize this is that a lot of such interactions go on and escape data storage. They're not available for capture. We therefore need technology that can link up with mHealth for automated data capture in a database. So that is what is needed to further, in the future, to improve on this method. But for now, we're going to have to use it as we have it. Once again, I think you've done a great job, and we commend you very much. Thank you. Hello, Dr. Adetunji.
thank you very much, sir, for the opportunity.
All right. Bye. So we're going on to the next paper. It's titled The Effectiveness of the Electronic Medical Record Compared with Paper Case Folder Documentation in a Tertiary Health Care Center. Dr. Osaji, Nicole Osaji is the one presenting on behalf of our colleagues. Dr. Osaji, you have the mic, please. Dr. Nicole Osaji. You need to unmute yourself in case you're talking. Is Dr. Nicole Osaji there? Please unmute yourself.
Use laptop. Put the camera directly in front of you. This is what you waste time. I beg to. So please, can you see my slide? I'm sharing it now.
We are seeing you, but we can't see you. Okay, don't worry. Dr. Nicole, go back to yourself. We'll share your slide.
Okay.
Okay, fine. You can maintain what you have. But share it now, right?
Put the camera to this side because my face is facing somewhere else. Bring the camera here. That doesn't feel at all. That. See, my face is facing this way. Put the camera here. Or turn in here. Yes. No. Stop. It's not that will be arranging camera.
Dr. Nicole, just carry on. If you have it, we're already sharing on your behalf.
Okay, sir.
Yeah, so just carry on. Can you see it on the screen now?
Yes, I can.
Carry on, please.
Okay, remove this. Good afternoon, everybody. Today, I'll be presenting the effectiveness of the electronic medical records compared to paper case folder documentation in a tertiary health care center. Electronic medical records have been shown to improve the quality and effectiveness of services in the health sector. Leading advantages includes prompt decision-making and increased ease of communication. But despite this, there is a paucity of evidence-based documentation in Nigeria. The objective was to determine the difference in the number of patients encountered at the obstetrics and gynecological clinic during the period of use of the EMR, electronic medical records, compared to a similar period of paper case folder records. It was a cross-sectional retrospective review of the outpatient medical records from 2014 to 16, when the paper case folders were used, compared to 2017 to 2019, when the electronic medical records were used in the outpatient. Now, the total annual patient encounter seen by the physician before and after introduction of the EMR, the difference was noted. And then we defined effectiveness as the difference in percentage between the two. We noted a 90.3% increase in the number of patient consultation during the period of EMR use. A total of 18,192 patients were seen compared to the period of paper case folder records use, 8,932. In addition, there was a marked decrease in the number of missing case records and an increase in ease of tracking records. Conclusively, the use of electronic medical record was associated with a substantial rise in the number of outpatient consultation compared to paper case records. There was also an associated increased ease of retrieval of records with reduced incidence of missing records. The use of electronic medical records is more effective and efficient. Thank you very much.
All right, thank you, Dr. Nicole.
Thank you, sir.
We appreciate you for your very clearly written work.
Thank you,
so we
sir.
invite comments, questions from the participants. Okay. Now, Dr. Nicole.
Yes, sir.
How did you and your colleagues, what mechanism did you and your colleagues use to ensure that the differences you observed were attributable to the use of EMR?
Thank you, sir, for the question. We had in mind the fact that some confounding variables, such as perhaps increased visibility due to the electronic use of dissemination of information, or increased use of these electronic medical records in case of with regards to diagnosis and then treatment and patient satisfaction, could also have contributed to the increase in patronage of patients. However, because we wanted to start with a descriptive study to have an evidence-based data first of this substantial increase, then subsequently we'll have an inferential analytic study where we'll be able to demonstrate the causal effect relationship on the outcome. And then we'll now pinpoint the exact factors that could have actually led to an increased patronage of patients outside the use of electronic medical records. So yes, this is a descriptive study, and we can't really demonstrate that this is due solely to the electronic medical record, but we can associate it for now until finally we have an inferential analytic study, and then we can say for sure that after controlling, perhaps using a logistic regression, after controlling for the confounding variables, then we'll be able to say for sure, conclusively, that it was solely due to or not solely due to the electronic medical records.
All right, Dr. Nicole, I can see you have made efforts to make it clear that there is no undue attribution there. But
Yes.
let Dr. Nabudoso wishes to make a comment. Dr.
Okay.
Nabudoso, please.
Hello, Dr. Nico.
Good morning, sir. Good afternoon,
Morning.
sir.
All of them. Evening too. I hope you are doing great.
Yes, sir. Thank you, sir.
Yeah, I was so excited when I saw your paper, and then Mike told me about it. And it was one of the very first ones that we accepted because it was homegrown and it looks quite nice and enticing.
Thank you so much, sir.
And it was exciting.
Thank you.
And we're quite glad. And I'm also happy with the way you have made the presentation. You'll be able to create time for this conference. So it shows that you're doing quite well, and we're always very glad about that.
Thank you
What
so
do
much.
you think about now? Yours is a privately funded setup. So how would you, based on what you presently find, which you have aptly put as being an association for now, how do you think that this could do in a public sector healthcare system?
Okay, sir. Thank you so much, sir, for the question, sir. From the findings of this study and the conclusion that emphasizes the association of a substantial rise, the implication in the public health sector would be basically one, to spur them into carrying out, first of all, spur them into engaging in electronic medical records, which will help a lot in their patient delivery services. However, it will also spur them to carry out another study with a better, in quotes, a higher grade of evidence, an inferential analytic study that can actually give the causal pathway. And then you can, a definitive conclusion can be made subsequently. Outside that, it can also help to engage the public sector in this electronic means of consulting patients, and it will also increase the outcome and reduce the maternal mortality, perinatal mortality rate as well. So it's a good thing to engage in, it's a good thing to advocate its use. However, we are still based on the premise that this is a descriptive study, it's a descriptive study design, and an inferential analytic study will be more sufficing to make a solid statement in the public health sector.
All right, thank you very much.
Thank you, sir.
When you say it really fits, you accept it. The cost is not good.
All right, Dr. Nicole.
Yes, sir.
Yeah, thank you very much. Before doing anything that's analytical to any detail, the least I would plead with you to do is to compare differences in data over the same period last year, so that we can at least exclude normal seasonal variation as a contributor to the difference that you observed.
Yes, sir.
It is, if you want to be a bit more analytical, I hope you know the kind of analysis you run. We'll then be doing what we call a difference in difference. That is beyond what we can describe here immediately, but that's just to guide your thoughts. We need more evidence, strong evidence to help inform the benefits of electronic medical records. You would notice that the sorry for the interruption.
Yes, sir.
Yes. So we need more evidence to inform EMRs. One of the things that's of concern here is this. There are some people who are of the view that merely changing from paper to electronic medical records is not necessarily beneficial. Such views have been expressed. So we need evidence to be sure that your position is what can be recommended. If not in this study, you may wish to conduct further studies in that direction. Once again, thank you very much.
Thank you so much, sir.
You have contributed to the world of evidence for e-health. All
Thank
the
you so
best
much,
in your
sir.
career. Please effect some of these additions and changes and see how you can improve on what you have given us before you submit for final production, for final publication in proceedings, conference proceedings.
Yes, sir.
Right.
Thank you, sir. Doctor, let's unshare the slides. You can unshare it. So I will log in with mine.
I thank you very much. We just had a brief interlude. Is Oriri O ready?
Yes, sir. Yes, sir. Yes, sir.
Right. So we have here a paper titled Towards a Teleconsulting Framework for Pediatric Medicine in Nigeria.
Yes, sir.
Authored by Oriri O. Okauha, yes, KC. So, Oriri, you have the floor.
Thank you, sir. Good morning, sir. Can you hear me, sir?
Yes, we can hear you very well, and you are sharing your screen very well too.
Thank you, sir. Good morning, sir, ladies and gentlemen. My name is Oriri Omena Ofajemu, a PhD student from Igbenedion University, Department of Computer Science. My supervisor is Dr. Okao from the Department of Computer Science, University of Benin. My paper is titled Towards a Teleconsulting Framework for Pediatric Medicine in Nigeria. Introduction. Today, we face a salient problem in Nigeria and globally too. The problem is the high mortality rates of children between the ages of 0 to 5. Estimatedly, 10 million children die every year globally, despite concerted efforts from international bodies, governments, and other organizations. It has also still persisted. It has also still persisted. Reputable international organizations like United Nations, like UNICEF, World Health Organization have conducted research in this area, and their reports are startling. For example, UNICEF, from its report, says that an estimated 29,000 children die annually due to causes that are preventable. World Health Organization states that 4 million children die annually between the first 4 weeks of their birth, and a significant proportion of those kids die within the first 24 hours of their lives. In sub-Saharan Africa, the statistics is even more worrisome. A child born in the sub-Saharan African belt is 10 times more likely to die than those in the developed world. Nigeria has one.
Sorry to interrupt you, Riri. Let your slides show what you're saying, please. You only have your.
I'm sorry, sir.
First, yes. Carry on.
Sorry. Okay, sir. In sub-Saharan Africa, sorry for that, sir. In sub-Saharan Africa, a child born is 10 times more likely to die than one that is given birth to in the developed world. Unfortunately, Nigeria has one of the unenviable records of high mortality rates in sub-Saharan Africa. Now, chiefly, the reason for this is because most of these deaths occur in our rural areas, which are remote, and over the past decades have always been neglected. Unfortunately, our healthcare delivery system in the rural area is very poor. It has the following characteristics. It is poorly funded, poorly staffed, and poorly managed. Poverty also is another problem that is plaguing the African continent and Nigeria. And because of this, accessibility to healthcare is quite difficult. COVID-19 pandemic, which came in last year, unfortunately worsened the problem and exposed the inefficiency of the Nigerian healthcare system. Now, what is the solution to this problem? The problem actually is the wide gulf that has been created between the patient and the skilled medical professional. And the solution to this is a technological-based one, adopting telemedicine. Now, what is telemedicine? Telemedicine is simply telemedicine is simply a multidisciplinary research application using advanced techniques and technology for information processing, telecommunication, biosensing, and artificial intelligence, primarily skills to deliver healthcare to a distant person from the provider. Now, what are the goals of telemedicine? Telemedicine has two goals: increasing access to specialty services, thereby allowing the patient to be treated locally and retaining their health within the community. Two, decreasing professional isolation of rural health care providers. The benefits of telemedicine are many. They include lower costs to the patient, improved access to healthcare, preventive care, convenience, and also slowing down the spread of infection. To the healthcare provider, it reduces the overhead expenses, additional revenue stream is created, less exposure to illness and infection, patient satisfaction, and the ability to attend to more patients. Now we'll go to related works. State of telemedicine in Nigeria. Nigeria has equally advanced in our use of ICT in healthcare, although the full potential of these applications have not yet been realized due to the lack of synergy amongst the various stakeholders. Now, the stakeholders here include the patients, the hospital, the doctors, and the people that provide the service, hospital services, including the community too, and the government. These issues of low coordination has brought about the replicated efforts, wastage of resources, and reduced health outcomes. To address this, a health ICT strategic framework was launched and was expected to be implemented by the year 2020, which unfortunately was plagued by the pandemic. In Nigeria, however, there's little to know if the healthcare strategy framework actually took into cognizance the individual level of telemedicine adoption from clinical perspective, since these clinicians are the primary users of the telemedicine system, and their acceptance is key to the emergence of a sustainable telemedicine system in the country. Now, telemedicine usage in child health care transverses teleeducation, teleconsultation, telemonitoring, telepractice, and also teleresearch. Teleconsultation can be simply defined as the process of establishing a communication link between the medical doctor and on the patient under the care and experts located in the distant centers. Now, the advantages of teleconsultation include an increase in access for the medically underprivileged. It also improves access for both rural and the urban child. It enhances care through swifter and more accurate assessment of results that would have been provided than through telephone. It also translates to huge cost savings in the healthcare system and in the patient's family. For the patient, for the inpatient in teleconsulting, in medical emergencies, telemedicine consultation can enable pediatric, excuse me, sir. Sorry. Extend the reach of the children receiving care in rural areas grossly lacking in adequate medical facilities. Telemedicine is increasingly used in providing specialty consultation to infants and children receiving care in community hospitals. For the outpatient, teleconsultation can be used for routine, less time critical consultation. Less urgent consultations provide many of the same advantages as emergency and urgent critical care consultation. Patients can receive these consultations in their own medical home, thus increasing its utility and importance. Because local access to consultation makes appointments easier to keep, the consultant has less difficulty and can attend to keep field appointments. And local care providers can be included in visits, increasing opportunities for care coordination and collaboration. Now, our framework, the proposed architecture model for...
Sorry to interrupt you, Riri.
Yes, sir.
You have exceeded your time, and I would request that you go to your conclusion. Please exclude things that are more like lectures. You seem to have a full paper that you are reading out to us. This is an abstract session, remember.
Yes, sir. Now, the potentials of teleconsultation on pediatric medicine is immense, especially in developed countries like Nigeria, where child mortality rates is really very high. The increasing portability of networked device will further enhance the ability of physicians to integrate telemedicine with their usual clinical overflow. With tablet computers and internet capabilities becoming more commonplace in our healthcare centers, cities, and communities, the possibility for expanding the reach and increasing efficiency far beyond the traditional realms are expanding rapidly. A telemedicine teleconsultation becomes an increasingly integral domain in standard medical practice. This technology is expected to soon be an essential component for the delivery of healthcare pediatric in this part of the world. Thank you, sir and ladies.
Okay, thank you very much. Unfortunately, you were not able to tell us what exactly you did. A good part of what you presented is more about what is already known. We wanted to go into what was not known.
Yes, sir.
Maybe I'll just give you a minute to tell us what exactly you did, to let us know what new knowledge you are contributing. What's the exact thing you did. Please do not give details of justifications of your action. Just specify what exactly you did that constitutes your work.
Okay, sir.
Do not try to advocate for anything at this point.
No, I'm just going to give you some, sir.
Yes.
I just put the slide on. The work was to develop a proposed architecture framework for teleconsulting in the pediatric system in Nigeria. Now, the scope of our work entails Okada, Usen, and Benin. We found out that in Usen and Okada, the healthcare delivery system is quite problematic, especially when it comes to the delivery for children between 0 and 5, and the mortality rates, it's very high. So our goal here was to develop a system because we found out that it is the gap between the patient and the specialist, the pediatrician in this case, that results in most of these deaths, which are preventable. And if healthcare is delivered on time, would save a lot of lives. So we designed a framework. And to get this framework, we discussed with key stakeholders. We identified the key stakeholders in the system. One of them, they include the child represented by the parents, the doctor, the physicians that will give this healthcare, the nurses, the host community too. We integrated, we sent questionnaires, we discussed with them through phones or on site. And the information that we're able to get, we're able to work on the system that we had to deliver what we are proposing right now. And with the system that we have proposed right now, we believe that that gap will be bridged towards reducing on the mortality rates of the rural child in those areas, sir.
Thank you very much.
Yes, sir.
So we'll leave the floor open for discussion, for comments, for questions. But as that goes on, I want to commend you for the work that you have done. We hope that this will be able to contribute to transitioning where necessary into a teleconsulting framework.
Yes, sir. Thank you, sir.
For clarity, what exactly is the patient supposed to do or the caregiver supposed to do in this framework?
Okay, we're going to adopt teleconsulting. And when we want to adopt teleconsulting...
No, sorry.
Yes,
I want my question to be very clear.
Okay, sir.
What exactly is the rural patient, looking at this framework, what exactly is the rural patient expected to do and how? Don't go into, is supposed to send a message, right?
The rural patient is meant to go to a telehealth center, which will be equipped with the teleconsulting system. He will get his data, his vitals taken through a series of biosensors, which will be sent over the internet to a medical server, which now links up with the doctor, the pediatrician, who looks at the details and can now get a full diagnosis of what is wrong with the patient and send the vital results or diagnosis for treatment of that patient, sir.
All of this sound grossly over-enthusiastic in my view. The reason is that what message is there that the patient is going to send that will lead to full, what you call full diagnosis?
Okay, we're going to take the biosensor is going to take heart rate. We're going to take the weight. We're going to take the temperature.
Also, I asked you what exactly would the patient do?
Okay, sir.
Because the pulse rate and code don't happen on their own.
No,
something has to be happening in the body of the patient that will then be transmitted into a device.
Yes.
So the patient has a responsibility to do something. It is what the patient is expected to do that is the core of my question, because if the patient doesn't get it right from the beginning, then data required for the remaining part of the processing will not be available.
Yes, sir. When the patient gets to the health center, he is hooked up. The child is hooked up to a series of biosensors. These biosensors will take this patient's vitals, like the heart rate, the weight, the temperature of the patient, and that data is fed to the doctor. The medical, because the patient is most likely going to be a patient that is already in the system. His records are already kept in the medical server, previous ailments and the rest, and all that is now made available to the doctor at the other end. The doctor takes all this and is able to now diagnose what is actually wrong with the patient and send the appropriate measures of treatment back the same part, sir.
Where will the appropriate method of treatment come from? From the machine?
No, not from the machine, sir. There will be a doctor at the other end, a health giver, a healthcare giver at the other end. The patient is a rural child, and the rural child is not just going to go and hook himself up. That's why he goes to the health center. And at the health center, he meets a doctor. The doctor attaches the biosensors to the patient, gets all the necessary information, and sends all that down to the computer system, which links up with the doctor, and the doctor can get the case note or the case file of the patient also from the medical server, sir.
So are we talking of one doctor here or two doctors?
Now, from the chart, you can see you have a team of doctors or a consultant. They work in teams. And that's the team that now makes the full diagnosis and sends back to the other end, where a doctor too liaises and gives the
consultant.
Yes, sir.
Okay, so if I understand you well.
Yes, sir.
A rural patient goes to a rural health center.
Yes, sir.
Where there is a doctor.
Yes, sir.
Who connects these patients to a certain device.
Yes, sir.
And signals are sent through that device, processing takes place.
Yes, sir.
There is data capture or further processing, which is then sent to another doctor at another end. Am I correct?
Yes, sir.
Okay. So what you're proposing is that the information generated at the index contact of the patient with the health team in the rural area can be added to pre-existing data.
Yes, sir.
in a system to inform a target doctor or team or consultant.
Yes, sir.
To enable a decision.
Yes, sir.
And this is now fed back to source, if I'm correct.
Correct, sir.
All right. I want to be sure I understood you clearly.
Thank you, sir.
Thank you very much for this innovation. But there are some assumptions I would strongly advise you to please go back and work on. First of all, a typical setting that will require this model you have developed does not have a doctor. If you are trying to solve a problem of lack of sufficient human resources, health human resources in rural areas, a model that assumes that there is a doctor in the rural area will not sell well. It in fact gives the impression that the doctor there probably should not be there, because if you're in the rural area, it should be rare for you to require this. Otherwise, the patient should go over. The question will be, what is the gap or what is the inadequacy that you are addressing? Is it a knowledge gap? You feel the doctor
in the rural area does not know enough, and in the one that's that is called consultant knows better, and that consultant will now have feedback to the doctor in the village who doesn't know enough. That appears to be the basic assumption here. But the real setting is not quite that way, and it doesn't function the way you have assumed, which means that it's very important that there is robust interaction with the system in order to understand the problem. It occurs so often that models are developed without understanding the basic processes. What happens? What are the needs? Where are the gaps? Once these are not properly done, then you may run into a problem in developing appropriate technology.
Yes, sir. Agreed, sir.
It will help very much if you could please work in that direction. But what you've done is a good idea. It is conceptualized, but you need to rework some things. If you're talking of a health center where there is a community health extension worker who does not have more than very basic and elementary knowledge, but is able to communicate what goes on, then perhaps that will be fine. I'm also asking whether this communication will be real time and whether it's a two-way communication, two-way real-time communication. So that means that the health worker in the rural area where there is no doctor is able to converse back and forth continuously and get the kind of information required for intervention. If that's what's assumed in your model, then please let us know clearly. If not, also let us know.
Okay, sir.
Okay, if you don't have a response immediately, that should just be fine. You can still go.
I do have a response, sir. The proposed architecture will work in both ways, real time and store and send. It actually depends on the nature of the ailment, because I couldn't just, because of the time frame, we're looking at both inpatients and outpatients, and also emergencies. Now, if you are an outpatient, we can use the store and send. You can take all your vitals and send them, and the response doesn't have to come on at real time. But when it's a case of an emergency, then we deploy the real time.
All right, thank you very much.
Thank you, sir.
All right, thank you very much. I will request MEHID Hospital to follow on this. She's asking, or somebody there is asking us some of the limitations highlighted. How possible is it for the biosensors to elicit chorus crepitations in a child with cough and fever in a rural setting? This is a divide between in and outpatient care. Let me not subject the author to this question. The assumptions made in the design of this model do not capture the question you are asking. If this kind of question is best asked, if there is a team doing this study that includes medical doctors, and then we are able to determine what inputs can generate what you are describing. That, of course, means that Limi Hospital is saying, if we look at it closely, that one limitation of your model is that it overestimates its ability to capture biosignal sensors, to capture biosignals. The sensors you're talking about are unspecified. There is a limit to which it is applicable. But again, not all model, there's no model that's perfect, okay? Every model has its limitations. And what Limi Hospital is saying is, please pay a little more attention to the limits of what you're doing. In the medical world, we do a lot of that. In fact, if you don't elaborate on your limitations, it is taken that you are not giving due attention to real-world utility. And then there are ethical and legal issues about that also. Thank you very much once more. I will not belabor you with that at all, because I'm not sure you know what coarse crepitations are. Coarse crepitations are even different from fine crepitations, and you may have quite a pretty bit of a problem there. And why this question is important from a clinical point of view is that it may determine whether or not this child will be alive. Pneumonia is not the same as an upper airway infection. So these are issues that are not in the domain of the author of this paper to address. Never mind, he has a white coat on. The man is a scientist. That's why he has it on. He's not a medical doctor, I can tell you that. Thank you very much.
Thank you, sir.
Yeah. Okay, we don't have a new question. So we appreciate you very much once more, Dr. Riri, for thinking through this. One of the advantages which I didn't see him mention, but I think it's worth noting, is that the system that captures this data, insofar as it is continuously updated, will form a robust database that will inform long-term monitoring of referrals. What is described is actually a referral system, in which case there is back and forth referral almost synchronously, and that's going to add value to health systems. The details of how inputs and outputs are generated, what should be fed in, the kind of input the doctor at the other end should expect, are beyond the scope of this presentation. What is important is that we have something that is being proposed and that has the potential to improve consulting in a system where there is no ready access to an expert team. Thank you very much, Riri and your colleague, for a job well done.
Thank you, sir.
So please make the appropriate modifications and submit your work for publication. We shall get back to you. Thank you once more.
Thank you, sir.
Chance, that's right. Okay, so we are looking at the questions that are running in right now. We will just okay, Uriri, thank you. You may step down now. We'll take the next abstract. The next one is on e-health for universal ear and hearing care, a scoping review of smartphone-based applications. This is by someone called Brima E. Is it a single author or we have two authors here? Single author, I guess. All right. So is Brima E ready?
Good afternoon, everyone. I am trying.
Okay, Brima, are you able to share?
I am trying to do that right.
I can tell that you are likely to have challenges sharing because of the nature of your network. I actually advise you not to share, please, so it doesn't put a burden on your network, on your data. We will share from our end. Is that okay? Brima?
Fine. Thank you so much.
So, Brima, we have your work displayed now. We are sharing for you. We'll advise that you switch off all videos and pictures and even all other files, put them off in your system, have nothing else on except your Zoom so you can communicate with us. That way your system will function better and your data will be better used for this purpose.
Okay, thank you. I appreciate that. Thank you, sir. Sir, can you hear me?
Yes, we can, loud and clear.
Okay, thank you so much. Thank you for the opportunity to present my paper today. My name is Brima. I'm a consultant ENT surgeon, and I'm presenting e-health for universal ear and hearing care, a scoping review of smartphone-based applications. Next slide, please. So I'll be using this outline. Next slide, please. Ear disease has become a major burden around the world. This is more so with developing countries like Nigeria. The burden of ear disease is higher here. 80% of people with hearing loss around the world live in low and middle income countries like Nigeria. There's a significant shortage of ear and hearing care professionals everywhere in the world. Again, this is exacerbated in our situation because we also have a high burden of disease. Smartphones are ubiquitous now around the world, and they may lend themselves to bridge the gap in provision of ear and hearing care. The objective of this study was to determine the scope of ear and hearing care services that can be provided to patients using smartphone-based applications. The methods I employed was, first of all, to define the studies that could be included. I included all preclinical and clinical studies. These studies could involve patients of any age, in any setting or not. They needed to use a smartphone-based application, including those that needed an accessory to be attached to the smartphone. And if they were providing any ear and hearing care service at all, they could be included in the study without including proof of study was carried out following the PRISMA guidelines, and the search terms were smartphone and hearing or ear or audiology. Next slide, please. A total of 973 papers were retrieved after removal of duplicates and two-step screening. 154 unique studies were eventually included in the review, subsequently by full text review to arrive at this number, because it's just a scoping. Because I had such a heterogeneous group of studies with different study designs, it was impossible to do that. Next slide, please. The studies I found covered the entire breadth of ENT service, string from telemedicine apps, some utilizing open source apps like Zoom, to examination, investigation, and even treatment. Most of the apps, about a quarter of them, dealt with hearing threshold measurements. This was followed by otoscopy applications, and then applications which were concerned with hearing conservation as well as education. One of the applications was to gather data from an entire region, that's the European Union, which was summarized in real time and could provide policymakers with data to make informed decisions. I thought that was a very interesting app. Next slide, please. The type of studies that I found were mostly cross-sectional analytical studies in which applications that had been designed were compared against already existing gold standards. And we also had a large number of proof of concept studies. In other words, these are applications that are still being developed in the lab and yet to be deployed for full clinical use. Only 3 studies were randomized clinical trials. Next slide, please. So I apologize for this huge table, but I didn't want to cut it. Over 30 countries in the world had developed various apps for various areas of ear and hearing care. The developed world had the bulk of these developed, or 1/3 of the publications. However, one LMIC stood out, and that's South Africa. South Africa was responsible for 15.6% of the publications, and most of them centered around their hearing threshold group of apps, the HearX group of apps developed by the University of Pretoria, which has now been adopted nationally for hearing screening in South Africa. Next slide, please. Most of the applications, as we have said, are targeted at measuring hearing threshold. However, from the very beginning of patient care, these applications could come in. For example, if a child starts crying with ear pain, parents can contact a provider through a messaging application like WhatsApp or Zoom, and then the provider could take history and then request the patient to use an application to look into the ear and obtain images of the tympanic membrane. Parents are able to do that using the app. The provider is able to make a diagnosis based on the picture and then provide treatment. For hearing threshold, if a patient feels like he can't hear properly, he could pick up his phone, use an application to do his hearing test, and the application will tell him if he has hearing loss or not. There are also other applications that you can use for self-fitting of hearing aids. In other words, you don't need to go to the hospital to meet an audiologist. You buy a hearing aid, connect it to this app, fit it by yourself to the level that hearing becomes comfortable for you, and you can use it thereafter. In other words, you could make your diagnosis and get your treatment from applications without necessarily having direct contact with health establishments. An interesting aspect of many of the applications in development is that they have now integrated artificial intelligence. So for example, the child I described who has to send otoscopy images to the physician, artificial intelligence systems are now being trained that they are able to analyze these images and make diagnoses without recourse to a physician. This has been done successfully for x-rays, where AI now outperforms healthcare providers in diagnosis on digital x-rays. This is also being done for histopathologic specimens, very likely to be okay. Next slide, please. In conclusion, the advent of COVID-19 has made the transition to e-health and health technology an urgent imperative, especially in low and medium income countries that need to provide high quality medical care on a relatively lean budget. Smartphone applications are a great well of opportunity, especially in the area of ear and hearing care. Thank you.
Okay, thank you very much, Brima. I think this is a very interesting paper, and you have very well drawn attention to key issues without going too far in your assumptions. You are very careful about raising too many expectations. But I have one quick question from you before we go to our members, our viewers, participants from other ends.
Okay, thank you. Please.
Would you want to make a quick comment on the economics of this technology?
Yes, I would. Some of the applications, especially the hearing threshold applications, have been found to be far cheaper than the standard audiometry that is done. The equipment are bulky, they're expensive, and then you have to maintain them going forward. However, these smartphone applications, some are free, some are not free, but once they are downloaded onto your phone, you are able to use them at much lower cost than the actual larger equipment. Interestingly, for endoscopy, there were 3 papers that showed that as an alternative to using an endoscopic light source, you can actually channel your smartphone touch using appropriate attachments to perform endoscopic surgeries in the ear. So that eliminates the cost of an endoscopic light source tower.
This is very interesting indeed. What I'm beginning to think that we need to convert this or translate this into real practice. Perhaps you and your colleagues should begin to develop new systems in your practice area where you can, in fact, make this happen. You might want to start on a pilot scale and watch it grow. And you publish what you have done. That becomes further evidence that we can transit from where we are now to where we ought to be. The economics of it is absolutely important, absolutely important. And I must commend you very much for choosing to do a scoping review. Scoping reviews are relatively recent and yet so powerful. They're relatively easy to do, but highly informative if properly done. I noticed with care that you excluded some papers, obviously because you're careful not to have variables that do not contribute to your objectives and variables that might explain, that suggest what you do not intend. So with that in mind, would you want to recommend more scoping reviews in this area because of our need to take advantage of M-Health and the other values that come from ENT diagnosis using electronic medical records?
Yes, sir. I think that these scoping reviews are important, even though I've been very familiar with a lot of applications. Once I did this review, I found that there were so many more that I had never heard of and I wasn't aware of. So these scoping reviews help to shine light on some of the areas that the apps are not so popular, and also on those in development, so that if you have an interest or it's something that you could develop for your environment or modify for your environment, that can be done. So I think that scoping reviews are really important for us, especially in LMICs.
All right. Thank you very much indeed. Are there questions? Are there comments? Somebody here says, your study makes an assumption that all users must have a smartphone. What happens to those without smartphones?
Yes, one of the issues that COVID has brought up is the issue of the digital divide that exists in the world. What we find is that smartphone penetration is not as much as we would see in the developing world here. For example, the reading for today I saw said the smartphone penetration is about 98 million when I looked at it, and that 50% penetration, that's quite low. But it's a place to start from, because what we have, we currently cannot tend to 50% of our population in ear and hearing care. There are less than 200 ENT surgeons in Nigeria. There are less than 50 audiologists in Nigeria. So if we can reach the 50% that has smartphones, that's a step in the right direction. While we do other things to try and bridge the digital divide that we have in our country.
Well, I wouldn't know the source of that data, but we have enough information that suggests that Nigeria has at least one of the highest levels of smartphone density. So you might want to also look at that in the literature and anchor your proposal on that fact. Yeah, thank you very much. Well, Brahma, I think you've made us very proud, and there are great expectations. All the best.
Thank you so much, sir. I'm grateful. Thank you.
Is Asogwa, I'd like to ask, please, is Asogwa Henry online, or anybody representing him, or any of the authors of the papers the authors of the paper titled Information Technology Adoption in Family Planning and Effect on Reproductive Health among Different Income Groups in Nigeria? Asogwa Henry or any of his colleagues. If you're online, please indicate, let us know. Okay, we're trying to arrange for the next presentation. The person who was supposed to present is yet to show up. That is the authors of Information Technology Adoption in Family Planning and Effect on Reproductive Health among different income groups in Nigeria.
So I think that answers the point. But critically, the idea of handling pre-appointment to is very important. It makes assessment faster, even when the patient presents himself. The doctor is able to make much faster assessment and take very good decision. When management has already commenced before coming to clinic, it also makes the entire management, clinical management time shorter. And these are important economic issues. So we have to have you highlight these in the next, in your venture submission. They're very, very important work. Now I'm going to ask you. for all purpose of directorship law. For all purpose of directorship law.
Right. Once again, good afternoon. We see that the next presenter is not available to present. Right now, we'll start our break. The lunch break is for 1 hour, and we shall recommence at 2:30. Thank you for your patience, and thank you for participating. Good afternoon. It's 2:30 and it's time for our last session. We're going to take all the remaining abstracts that have not been taken. They're all scheduled for this period. And I will enjoin all of us to please be on ground. Okay, so at this moment, we have a paper titled Towards a Telemonitoring System for Elderly Outpatients in Nigeria. and Omorugbe H.O. and Ukaoha K.C. are the authors. So shall we have Omorugbe present the paper? Omorugbe, please indicate whether you want us to share your paper on screen or you want to share it yourself. Okay, we have information that you did not send us your PowerPoint, so you will have to share your slide. Okay, Harry, you're good to go.
Hello, good afternoon.
Yes, good afternoon. We are with you. Thank you.
Okay. Yeah, I'm sure that I'm sharing my slide. I hope you can see my slide now.
Yes, we can.
Okay, I will be talking on the telemonitoring system for elderly outpatients in Nigeria. My name is Omorugbe Harry Osasu. I'm a PhD student in the Igbenedion University, Okada, Computer Science Department. This paper is co-authored by Dr. Koa Kingsley from Department of Computer Science, University of Benin. Just emphasis on trying not to overflow many of the issues that have been raised and addressed in the last couple of days in defining what telemedicine is. But for the purpose of this presentation, I will just quickly take a cue from what the World Health Organization says about telemedicine. Talking about telemedicine, the World Health Organization looked at it as healthcare service where distance is critical factor by all healthcare professionals using information and communication technology for the exchange of valid information for diagnosis, treatment, prevention of disease and injuries, research and evaluation, and for the continuing education of healthcare providers, all in the interest of advancing the health of individuals and the communities. However, sometimes these definitions have left many of us looking at telemedicine as targeting the younger generation. So it's always a misconception when we talk about technology. People believe that technology is for the younger one. So we decide to look at it that when we think of digital technology, they're thinking that it's for younger individuals using their smartphone and other digital device. It's wrong. So, but this line of thinking that doesn't necessarily apply to telehealth, because telehealth does not have barrier between the young and the old. But however, older generations can use telehealth technology to improve their access to care and reduce the cost of healthcare service. On that basis, we decide to look at a very important aspect of telemedicine, which is actually telemonitoring. We are looking at a situation whereby patients have undergone basic treatment or major treatment in the hospital, But when they are out of hospital, they need to continually have one-on-one correspondence with the doctors or nurses or caregiver to be able to understand their situation or how they are responding in their patient situation. Now, we also notice that this has become very difficult for many persons, especially when they are in the rural communities. Even when they are in the urban communities, sometimes many factors may affect their inability or ability to access the tertiary health services in a continuous mode. So on that basis, some of them end up not really responding. So we've decided to come up with a model, knowing fully whether a lot of work can be done in this aspect of telemedicine, using mobile services and all. We tried to look at work that were done by Lajescas in 2007. We looked at the work that was done by Okowa and Bokare in 2012. We look at work that was done by Kowa in 2016. Having looked at all this, we felt that there were some gaps in their earlier work. So we decided to describe a general purpose framework that can be used to easily implement telemonitoring application for elderly outpatients on an individual basis, by extending the model that were earlier proposed by Okowa and Agbokare in 2012. And the gap we found in that model allow us to think of a better way. Now, in thinking of a better way, we decided to look at how do we come up with this new model. So we did a lot of research, getting information from the concerned stakeholders, which are the medical practitioners, the government sector, the patients, and the community. In following some of those processes we came up with a proposed design. In our proposed design, in trying to extend the existing model that were done by Kingsley and Obokare in 2012, we discovered that some of the challenges that was addressed then, that technology have evolved over these years, and there is need to improve on telemonitoring system. So our model actually addressed 12 major areas in a telemonitoring, 14 major areas in a telemonitoring system, starting from the hospitals and all. So in our proposed diagram of the model, if you are seeing the diagram, first we have the hospital, the primary health care centers, and the teaching hospital as a case, which is the primary center where this patient must have taken treatment, but now it's an outpatient, it's no longer there, but you need to continually to be monitored. And there is a database that has information about this patient. We also discovered that some of these elderly persons, some may have grown from the technological background of knowing how to use mobile system, telephone. So we have a session where we say the elderly person that has technological ability, so such elderly person can effectively communicate back with doctors at the hospital. But there are also patients that don't have this technological ability. They're probably, before the advent of GSMs and all the mobile technology, they have grown into the bracket of the 60s and all. So they are not flexible with mobile devices. So in such case, such person can have a non-medical expert. It might be their children, it might be their caregiver at home, as the case may be, who help to relate. We also discovered that there are elderly persons, because of their age, find it difficult to be able to keep up with whatever is happening in the tele world. So we took a cue from what you have in the Gmail email system. When you are registering a child who is less than 18, the Gmail system will simply ask you that you are not qualified to register because you are less than 18. So on that basis, they say parents can do what they call family link. So most often when people get to age, they become like a child again. So we also felt that there is a need for a system that can implement something that those who will develop tele-monitoring softwares or platforms in the future should have a way in which family member phones are tied to the elderly member phone in such a way that when they fail to meet up or to take probably their medication and all that thing, these family member phones are alerted based on the time that the doctor would have prescribed for them to take their medication, maybe twice or 3 times a day. But when those things are not properly done, there is a reminder through the family mobile phone. We also notice that not every person has smartphone. So for the very fact that not every person has smartphone, There is also an advantage of using the USSD code system, in which, if irrespective of the kind of phone you have, you just use short code message. So you can also begin to relate back without having internet access, but you just have a phone in that case. So when we look at this, we also discovered that because of the issue of privacy and some level of security, and people are worried in the health sector about the confidentiality, we also felt that there is a need to incorporate a teleconference center. A teleconference center will be able to take care of some of the concerns that patients and doctors will raise. We also took note of the very fact that some persons might be far from the tertiary health center, so they need to have a tele center, a mobile kiosk. So that mobile kiosk can also be a stop gap for those who cannot go to the main. They can't use some of the technology, but when they get there and their situation needs some examination, the tele or mobile kiosk has some basic equipment that it might not be as robust as the equipment you find in the main hospital, but they are stopping major gap in which the elderly patient can go, and if there is any need for them to be prepared for transportation, or if the case be, they can take that. That was what we proposed. In dealing with this, we realized that in our interaction with medical practitioners, there were issues that were raised. Now, those issues that were raised, we left it in our observations of future work, which basically has to do with if patients that are outside are arising from the present situation. We notice that patients that are in the rural area may need some other equipment, and this equipment may also be increasing their costs, because the work that was earlier done by Kesley and Agbokare in 2012 tried to explain the very fact that this system will be cheap. But if we also discover that if patients are going to get some equipment like thermometers and glucometer to check their blood pressures, or they have to get pulse oximeter because of the COVID, it might not be everyday routine, this will also increase the pressure on them. So we left these things for future work, but we concluded our analysis that if we implement a tele-monitoring system, and if government have their role to play in it, we'll be able to achieve, or to a very large extent, the United Nations SDG goal. We'll be able to achieve that if we implement the proposed model that we have put before us. Thank you very much.
Thank you very much indeed. Your system design captures different levels of healthcare, tertiary, secondary, primary, and you're able to build a network where there's communication across different, between provider and the user. Would you want to share with us some challenges in building this system design?
Sorry, let me get the message properly, sir.
I can see that.
What challenges did you have in the process of building this system, given that you are having to interconnect user and provider, plus the communications technology, by a wide range of different levels of healthcare?
Okay, thank you very much. But one of the challenges is starting from the patient side. We noticed that the elderly, especially in the rural area, some of them were not flexible in using any of the technology. Some of them were not even aware of the existence of any of those technologies that they can leverage on in terms of telemedicine services. And also coming to the medical side, issues were raised about power, the sustainability of some of these things. So in the tele centers of mobile kiosks, questions were raised. If you go to the rural area, power is a problem. So how do we mitigate against that? We in our findings, we felt that in dealing with that, the issue of thank God for the environment we find ourselves in Africa, that solar power can be of immense use in terms of sustainability of power in the rural area. We also find out that in the hospital section, where you have most of the tertiary hospital having the support of government, we discovered that there is no well-defined mode of how to address telemedicine or implement telemedicine in the tertiary hospitals. But some private hospitals that have the resources are trying to implement, but majority of the patients don't go to these quote and unquote expensive private hospitals. They still go to the government hospitals, and the government hospital don't have the structure, they don't have the layout plan for implementing any form of care. Some of them didn't even have the basic computer to keep record of patients, so they are still done manually. So there is this challenge of reorientation, even putting the medical experts, whether both practitioners, nurses and all, to use basic telemedicine facility, that is ICT facility. That was one of the challenges.
Sorry, I'm not talking about the challenges faced by the practitioners.
Okay.
You conceptualize this framework.
Yes.
I'm asking whether you went through some systems analysis. I'm not talking about computer systems, but keeping in mind the different systems you are bringing together. For example, the way the tertiary health care system functions is not the same way as secondary or primary. It's also not the same way as private practitioners operate. And there are also different levels of affordability, which you alluded to moments ago. So my question is as to how you were able to come up with the conclusion that this is a workable arrangement, given the barriers, whether in your analysis of the internal systems of different types of institutions, you looked at, you empirically did an analysis of the workability. And if you did, what challenges did you come about?
Okay, thank you, sir. Yes, in coming to the point where we find ourselves, we looked at some work that were done earlier on in existing system. I was earlier trying to talk about the existing system that we have seen. And looking at those existing systems, we actually saw the challenges that they had. Some of those existing systems were implemented, those some were not effectively documented, but looking at those existing systems and what they intend to achieve, we took up from the existing system. I make reference to about 3 systems we looked at. The one by Citonon in 2014. We looked at the one by which we built our work on by Okoa and Bokare in 2012. When we looked at those systems, we discovered that the community, for example, there were some cultural barriers in even implementing telemedicine. In some of the community, by their religious belief and all, sometimes they are not, they don't allow probably access to their wives or whatever for treatment and things like that. All those things were not taken into consideration in the earlier system. So when we saw all those things, so when we were coming up with this framework, we were looking at if they don't need to live wherever they had the comfort of their own, and if they don't also want to implement a video call or whatever, SMS, USSD code were some of the things we learned. So we actually have problem in getting some of these people to respond, because some of them didn't want to respond because they still have this cultural barrier in talking to people about health issues and all. So it was also difficult trying to convince them the safety and security associated with telemedicine, because some of them believe that your relationship with the doctor is private. Now, if I go on this platform, it's like I'm exposed to the world. Nobody wants to talk about probably their health situation sometimes. So it was also a problem, challenge for us trying to convince people when we were eliciting for data, eliciting information, trying to find out if we want to implement a telemedicine structure to monitor them. Would they find it useful? Would they use it? But they were worried that if they enter into the telemedicine structure, they will be exposing all their health situation to the world. And they don't want that. That was a challenge for us. And it was difficult actually convincing some person that if we talk about implementing active security, it will not be a problem. That was a challenge.
Well, thank you very much. Maybe with time, we'll be able to engage in this better. It's one thing for components of the system to have challenges. It's a different matter to appreciate that at the point of developing the model to network challenges, there are problems also.
Of course, I know with time we'll be able to look at the operability of what you're saying. At policy level, there is easy alignment between what you have done and what is expected. But nothing says that it will work. The barriers to integration are more than just the absence of technology and the absence of skills. But there are internal mechanisms that are there. For example, what is the place of policy? What's the place of interoperability of already existing technologies? To what extent is it possible for each level of healthcare
organized or handled or managed by different levels of government?
To what extent would they be ready to willingly connect with a national network of data, a national record system? How is that possible? Health, you must appreciate, is not a unitary system in Nigeria. That means that state governments, federal governments, the federal government run their systems separately. There's nothing that expects that states will necessarily connect with what you are modeling. Nothing says that anybody will agree to this. It is having an agreement that can overcome these systemic barriers that I was asking about, not necessarily the difficulties that individual components of the systems have that necessitated the development of the barrier. Development of the model, rather. So thank you very much all the same. We know that this is work in progress, and you'll be able to capture other disciplinary inputs into what you are developing. Well done. Well done.
Thank you, sir. Thank you, sir. Thank you.
If there are questions, please let's have them. Okay, so Omorogbe will please appeal to you to kindly identify areas of opportunity for improvement in your work. We're going to publish this as conference proceedings after now in the Journal of Hospital Practice and Administration. Thank you.
Thank you, sir.
So who's next?
That's all.
I'm working on my phone, but it's off.
Okay, so that brings to an end the session on abstracts for today. We shall soon be closing the activities for the day. All right. A brief announcement. We have completed the sessions for today. And what we now wish to do is to introduce what to expect tomorrow. Tomorrow, the main activities are first a documentary on e-health and health informatics sites and services in Ultimate Health HMO and the ICT in the University of Benin. After which, we will have a documentary on e-health and health informatics sites and services in University of Benin Teaching Hospital. Those are the main activities for tomorrow. At 3 p.m., we're going to have a slight modification to the program as initially planned. What we're going to focus on will be the review of some existing frameworks that will help us appreciate more what we're doing. And then we'll look at some posters that tend to illustrate that. We'll look at that from existing literature of previous publications. That's to help people who could not submit posters and to help us engage better with what others have done on their posters. Thank you very much. So at this point, we would like to draw a curtain on today. We thank you very much, our dear participants, for being a part of what we have done today. And we can only hope for a better tomorrow. Thank you very much.